Let's do the warm-up for Neuro 20. First question, what patients are susceptible to Listeria monocytogenes? So think about neonates and also immunocompromised patients. So Listeria can cause neonatal meningitis, and also it can infect the amniotic fluid, and that leads to spontaneous abortion. Next, what name is given to red cells that have been partially digested by splenic macrophages? Well, these are called BIT cells, or the fancy official name is degmocytes. So the macrophages remove the denatured hemoglobin in the patients who have that G6PD deficiency, and the result is red cells that look like a bite's been taken out of them, so they're called BIT cells. And the last one, which nerve is being tested with each of the following reflexes? So the biceps reflex tests the C5 nerve root, triceps reflex tests C7, the patellar reflex tests L4, and the Achilles reflex tests S1. Okay, now we're ready for the lecture.
And now, it's time for the ulnar nerve circus featuring the high-flying interosseous. Thank you. Hello everyone and welcome to our step 1 video on the upper extremities, part 2. Okay, so in our last video, we attempted to memorize that brachial plexus, and we started learning about the nerves of the upper extremity and which muscles they innervate, and we started learning about some of the motor innervations as well. Now, in this lecture, we're going to go a bit deeper into the nerves of those upper extremities, and we'll also cover the high-yield pathology. Now, some of this is review from the last video, but that's good because this stuff is pretty dense, and repetition is the way to go. But again, we're not going to cram weeks of anatomy into 20 minutes. You may still need to sit down with your anatomy book and re-memorize the anatomy of the upper extremity. All right, so I'm going to go nerve by nerve, and we're going to start with the radial nerve. So the radial nerve is an important nerve in the upper extremities, obviously. The radial nerve innervates the medial and lateral heads of the triceps brachii muscle. Now, new evidence shows that the long head of the triceps is actually innervated by the axillary nerve. But the triceps in general are the major extensors of the forearm. Now, there is a deep branch of the radial nerve, and it innervates the supinator and brachioradialis. These act to supinate the forearm. Now, the brachioradialis doesn't follow the rules of the radial nerve very well, though. Now, most of the muscles act to extend, but the brachioradialis again acts to flex the forearm, and it can pronate a little as well, depending on the position of the arm. The deep branch also innervates the extensor carpi radialis longus, which is just next to the brachioradialis muscle, and it's going to act to extend the wrist. Now, the radial nerve distally will become the posterior interosseous nerve, which is going to act on multiple muscles to extend the fingers and the hand. Now, a couple of examples include the extensor digitorum and the extensor pollicis longus. So, when you think of the radial nerve, remember that it generally acts to extend the forearm, the wrist, and the fingers. Now, another hint for the muscles that the radial nerve innervates is the mnemonic BEST, B-E-S-T. For again, that's going to be brachioradialis, extensors of the wrist and fingers, supinator, and triceps. So that's BEST. So what about sensation? Well, branches of the radial nerve provide cutaneous innervation to the skin of the posterior arm and the back of the hand. Now, what about pathology? Now, one scenario where you might compress the radial nerve is with Saturday night palsy. Here we see radial nerve compression against the spiral groove of the humerus. So if you're passed out with your arm over a chair on Saturday night, as I often am, for hours and hours because you're drunk, then you would compress the radial nerve. Now, as a result, you would have weak wrist and finger extension, so you can get that wrist drop, a numbness of the back of the hand and wrist, and a weak brachioradialis reflex. All right, so you've lost your ability to extend. Now, when you hear wrist drop, then you certainly need to think radial nerve injury. Now, another injury that tends to injure the radial nerve is a fracture of the shaft of the humerus. The radial nerve tends to get damaged with a fracture along the shaft of the humerus. And make sure you see shaft in the question. Don't get this mixed up with a fracture of the surgical neck of the humerus, because that's a different injury and we see a different nerve involvement. All right, so now let's move on to the ulnar nerve. Now, in the forearm, the ulnar nerve innervates the flexor carpi ulnaris and the flexor digitorum profundus. Now, the flexor carpi ulnaris will flex and adduct the wrist. The flexor digitorum profundus will flex the wrist and flex the fingers. Now, there are multiple innervations in the hand. Now, first, we have the hypothenor muscles that act to control the hand and the little finger. It also innervates the third and fourth lumbricals, which flex at the MCP joints, and it's going to extend the interphalangeal joints. So remember this one because we're going to come back to that with some pathology. Now, it also innervates the interosseous muscles, which act to abduct and then also adduct the fingers. I would have a tough time performing my circus act without the ulnar nerve and the interosseous muscles. And finally, it's going to innervate the adductor pollicis, which acts to adduct the thumb. All right, so let's cover sensation. The ulnar nerve only provides sensation to the hand. It will cover the fifth digit and half of the fourth digit and the corresponding part of the hand. So the medial side of the palm and the dorsal hand. Now for pathology. Now, if you know the innervations, then you can reason out the pathology. The flexor carpi ulnaris and the flexor digitorum profundus work to flex the wrist and the fingers. So if you have a more proximal injury, then you get loss of wrist and finger flexion. Distally, with the ulnar nerve injury, we see what's called the ulnar claw. So remember that the third and fourth lumbricals acted to flex at the MCP joint and extend at the interphalangeal joints. So if we lose the third and fourth lumbricals, then the fourth and fifth digits will be hyperextended at the MCP joints and then flexed at the IP joints. With the interosseous muscles impaired, there will be more difficulty with abducting and adducting the fingers. You may also see hypothenar wasting as well. All right, let's move on to the median nerve. So the median nerve innervates almost all of the flexors of the forearm and many of the pronators as well. The pronators include the pronator teres and the pronator quadratus. The flexor carpi radialis and the palmaris longus will flex the forearm. The flexor digitorum superficialis and the lateral half of the flexor digitorum profundus will flex the wrist and the fingers, and the flexor pollicis longus will flex the thumb. So overall, think flexion and pronation with the muscles innervated by the median nerve. Now in the hand, the median nerve supplies the first and second lumbricals, which will flex the MCP joints and extend at the IP joints. The median nerve also innervates the thenar muscles, which includes the opponens pollicis, the abductor pollicis brevis, and the flexor pollicis brevis. What about sensation? Well, sensation from the median nerve will cover the lateral palm in the first 3.5 digits. There will be different presentations, though, depending on the location of injury to this nerve. Now, an injury to the elbow can result in something called ape hand deformity. Because of the loss of the innervation of the thenar muscles, the patient is unable to abduct the thumb, so the thumb will be unable to move the thumb away from the hand, kind of looks like an ape. Now, an injury to the elbow or even above may result in what's called the hand of benediction or Pope's blessing. Here, the patient loses the ability to flex digits 2 and 3, the index and the middle finger. So when you ask the patient to make a fist, they can flex the pinky and the ring finger, but they can't flex the index and the middle finger. So what does that look like? Well, it actually kind of looks a lot like the ulnar claw, doesn't it? Well, the difference is that the patient with an ulnar claw can't extend the pinky and the ring finger even at rest. Those fingers are chronically flexed. The hand of benediction is only apparent when you ask them to make a fist. They can't flex the index and the middle finger. When their hand is relaxed, then they can actually look almost normal, where the ulnar claw, when relaxed, always looks abnormal. Now, the other high-yield pathology associated with the median nerve is carpal tunnel syndrome. Very, very common. So this is a median nerve entrapment at the carpal tunnel enclosed by the inelastic flexor retinaculum ventrally and then the carpal bones dorsally. Now, the primary symptom is intermittent numbness of the thumb, the index, the middle finger, and half of the ring finger. Now, it occurs at night or during the times of compression, like typing on a computer. Now, at night, patients will kind of naturally flex their wrist while sleeping. Now, this can lead to permanent nerve damage, atrophy of the thenar muscles, and weakness of the palmar abduction. So on questions, look for the location of the numbness. Remember, numbness in the thumb, index, middle, and then half of this ring finger. Moving on to the musculocutaneous nerve. So the musculocutaneous nerve is a bit easier to remember. It innervates the coracobrachialis, the biceps brachii, and the greater part of the brachialis. Now don't get the brachialis mixed up with the brachioradialis. The brachioradialis, which we've already talked about, is innervated by the radial nerve. The brachialis is innervated by the musculocutaneous nerve. So what do these muscles do? They are the major flexors of the forearm and also work to supinate the forearm. The sensation supplied by the musculocutaneous nerve is the lateral side of the forearm. Pathology to the nerve will simply impair forearm flexion and supination. You can't do your curls real well. All right, moving on to the axillary nerve. Axillary nerve will innervate the deltoid, teres minor, and the long head of the triceps brachii. Now remember that the other triceps are innervated by the radial nerve. Now the deltoid acts to abduct the shoulder, the triceps act to extend the forearm, and the teres minor acts to externally rotate the humerus. Now the highest yield injury here is with a dislocation of the shoulder or fracture of, again, we talked about this before, the surgical neck of the humerus. An injury to the nerve will result in loss of abduction of the arm, weak flexion, extension and rotation of the shoulder, and loss of sensation over the lateral shoulder. Test questions will also ask which artery runs with the axillary nerve, and it's the posterior circumflex. Now let's move on to the long thoracic nerve. The long thoracic nerve, so this innervates your serratus anterior. Remember the mnemonic we talked about before was SALT, S-A-L-T. Now the serratus anterior acts to hold the scapula to the thoracic cage. The serratus anterior is also used for abduction beyond the horizontal position. The long thoracic nerve does not supply any sensory info. Now, without a functioning serratus anterior, the scapula is going to protrude out. We call this a winged scapula. The long thoracic nerve can be damaged to a blow to the neck or shoulder or has been known to happen after a mastectomy as well. All right, guys, so that was a bunch of info. Let's review it again in a game show. Don't look at your notes. I'm going to give you some muscles and you name the nerve that innervates them. So first one here, supinator, brachioradialis, triceps. The answer is radial nerve. Next. Flexor digitorum profundus, third and fourth lumbricals, flexor carpi ulnaris. Answer, ulnar nerve. Next, pronator teres, palmaris longus, first and second lumbricals. Answer is median nerve. Next, coracobrachialis, brachialis, biceps. That's going to be the musculocutaneous. Next, we have long head of the triceps, teres minor, deltoid. The answer is axillary nerve. Now, one last topic I want to mention that we sometimes see on tests is shoulder abduction and the muscles involved in the various phases of shoulder abduction. So there are 4 muscles responsible for shoulder abduction, but they don't all act at the same time. The supraspinatus will initiate the first 15 degrees of abduction along the vertical plane. So when the arms are at the sides of the body, to initiate that abduction, the supraspinatus is going to act first. Now the deltoid is going to function from about 15 to 90 degrees. And then finally, the trapezius and the serratus anterior act together to abduct from 90 degrees to 180 degrees. So let's take it one more step and review the nerves involved. So the suprascapular nerve innervates the supraspinatus, the axillary nerve innervates the deltoid, the accessory nerve innervates the trapezius. And then finally, that long thoracic nerve is going to innervate the serratus anterior. So if a patient has shoulder abduction problems, look precisely where they have the weakness. Is it with initiating, before 90 degrees, or after 90 degrees? All right, that's it for the video part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what nerve is damaged when a patient presents with the following symptom? And this is of the upper extremity. So first we have unable to fully extend at DIP and PIP, fourth and fifth fingers. Remember, that's going to be the ulnar nerve, and that ends up giving you that ulnar claw. Next, unable to flex index and middle finger. Remember, that's the median nerve, and that's that hand of benediction. Next, we have wrist drop. That's going to be radial nerve. Scapular winging. That's going to be the long thoracic nerve. Loss of sensation over fingers 1 through 4. That's going to be the median nerve. Next, we have cannot abduct or adduct fingers. That's going to be the ulnar nerve. Loss of shoulder abduction. That's the axillary nerve, as well as the suprascapular accessory and long thoracic. Next, we have loss of elbow flexion and forearm supination. That's going to be musculocutaneous. And then finally here, loss of wrist extension. That's going to be radial nerve. Next, what nerve is most at risk of injury with the following types of injury? First, we have fracture of the shaft of the humerus. Remember we talked about this? That's that radial nerve again. Fracture of the surgical neck of the humerus. That's going to be the axillary nerve. Anterior shoulder dislocation, axillary nerve again. And then injury to the carpal tunnel. That's going to be median nerve. Next, a patient falls off a motorcycle and lands on his right shoulder. On physical exam, you notice his shoulder has an abnormal configuration. X-ray indicates an anterior dislocation of his shoulder. What artery and nerve is at most risk of being damaged? So this is the axillary nerve, we covered that. And do you remember it? It's going to be the posterior circumflex artery because they run together. All right, guys, that brings us to the end of this video. I hope you learned something. I'll see you next time.
Good evening. Dr. Acula here once again for tonight's Ask Dr. Acula. Tonight's question comes to us from Paul in Los Angeles. Paul writes, "Hey there, Dr. Acula, your show is great and I dig your cape." Why, thank you, Paul. What condition is caused by lesions of the long thoracic nerve? The long thoracic nerve innervates the serratus anterior, which is located on the side of the thorax and acts to pull the scapula forward. Trauma to this nerve, in turn, causes the shoulder blade to protrude from a person's back. This condition is known as winged scapula. Great question, Paul, and you guys keep those questions coming. Now, I've got to fly.